let's sort of take you through the national health policy on some of the key issues and expectations of the national health policy. Now, this national health policy, the draft was put up on December 31st, 2014. It got approved on March 16th, 2017. The national policy was actually, many contexts are there. One context that many of us don't quite factor in or recognize so much, but I am fond of pushing in my classes, is India is a signatory to an international treaty, which I think the US has not signed. It is called the International Covenant on Economic, Social and Cultural Rights. The treaty was passed in 1976 and India became a signatory to it on April 10, 1979, and on the basis of a number of other key documents over there, there was the ICSSR policy draft, and there was a particular change, and the first 1983 national health policy was passed. Otherwise, why did you have a national health policy in 1983? Because after all, it had not happened since independence. Because at some point it was part of this commitment. And that Article 12, which commits India to a health rights framework, therefore it's important to keep memory of it, says, however, in its first para that you can have something called progressive realization. But the implication of progressive realization means that at all times you must have a policy which shows how you are going to reach them. So in a sense, under international obligations, you are bound to have a policy. A more immediate context to it has been also that the BJP manifesto by which it came to power explicitly mentions that it will pass a national health policy, and it also explicitly mentions that it will have a national health assurance scheme program. These are explicit commitments to it. The Congress had a similar commitment, but in some sense the BJP commitment was even more articulated. And as happens after a government comes into power, the cabinet secretary and the secretary to the PM will get the manifesto of the party that came to power, whether it is in the state or center, and pass it to all the departments and say, please show how you are going to implement this. It is a good thing, because in a democracy you want the mandate of the people to be implemented. And at least these positive aspects are an important thing. The political mandates which are otherwise are more. So they have to comply. And the compliance date was set. The ministries have to reply by when, and the ministry replied, by the end of this year we will put up a draft. And they put up this draft. So that was the sort of political context of it. And then the draft got terribly stuck. And when you read this policy, sometimes you may come around lines which you think are a bit absurd or a bit unthought of. Or believe me, there is no line in it which is not contested, debated, argued, thought of internally. These documents are not made in a very haphazard way, even if the final outcome looks haphazard. There are some spectacular lines which are merged on the absurdity. That absurdity is a resultant of 3 equally or 4 equally or 10 equally balanced forces pushing from different directions, and the resultant is something that nobody will get off the other way. So there was these intense contestations, and some of these contestations reflected in, if you were to examine what is there in the December 31st draft that was put up and the policy document that is approved. So it's a very good piece of study to see after this so-called public discussion what changed. And mind you, this was intense. The whole Chamber of Commerce wrote, the Indian Chamber of Commerce wrote, the American Chamber of Commerce wrote, international agencies wrote. People like FICCI and the CII hired senior retired IAS officers to run a whole program of putting together their thoughts. Brookings Institute and international think tanks wrote. Civil society also wrote. Civil society sometimes gets into the feeling that they made a lot of impact. And actually there were 5 or 10 letters among the sort of civil society that we are associated with. The People's Health Movement family would have written more than 5 or 10 letters out of 5,000. Of course, a lot of it may be sectional. Occupational therapists wanting to have their day. There was a lot of letters. Dentistry, professional associations are a bit of letters. So it's a whole. But the simple point that I am trying to say is, even where it appears non-serious, there's a lot of things which are not said. Even what is not said in a policy needs to be thought through as to why it was not said, why were the forces when it chose to remain silent. So a simple point saying is that we need to take it seriously. Even at one point we don't know how seriously they are going to implement it. Now, I'll take you through the policy and take you through some of the key formulations and try to show the alternative formulations that were rejected to arrive at that and the implications and inadequacies of this formulation as it is there, and also sometimes the strength of the formulation. So it starts with an introduction which sets out a certain context. So you have to have this question as to what's new, what has changed since 2002 that merits a new policy. Otherwise the 2002 policy is there. And it says there are 4 things that are new. The problem of reproductive and child health that dominated the Millennium Development Goal is a problem that has now, in terms of the total amount of deaths it caused, it has reduced greatly. Non-communicable diseases, chronic illnesses and emerging infections are a huge problem, and that's one change. One change is epidemiology. The other change is that there is a huge healthcare industry coming to place. And 3, and it doesn't quite link the 2, though it is obviously, is that there is catastrophic health expenditure, and impoverishment due to healthcare expenditure is a goal. In a way, it is to be articulated in a goal that it is not so in the other areas. And 4, it says that the fiscal space to implement these reforms are available. So what do we mean by fiscal space? It means the government now has so much economic growth, so much surplus, so much money, that actually there is more money to put on health as compared to, say, the 1990s where you had a fiscal crisis. Of course, what they don't say is that government policy is pushed by something called fiscal consolidation. And as part of fiscal consolidation, the government says that we will keep our deficit to less than 3.8% of the GDP, less than this percent of the budget, and it gives commitments that nobody is asking it to give, but it gives these commitments as part of its so-called governance strategy. Which really means that you cut down on your budget because you have to keep your budget. So it's not fiscal crisis that at this point determines the fiscal space, but the policies of fiscal consolidation that determine the fiscal space. That of course is one of the silences, many silences that you have in this whole budget, and we will trace many of these. So you are not really at any point saying, what does it mean to invest 2.5% of the GDP? What will it do to your fiscal consolidation strategy? Are you going to say we will relax fiscal consolidation to achieve these goals, or are you going to keep it within this particular area? How are the additional revenues that you are going to need for this policy coming? So that's basically the context. As we said, there were a larger international political context, the immediate BJP government's particular commitment, but there is a context that it lays out that we need to see. The articulation of goals and principles is nothing very remarkable. I would just draw a passing attention to the use of the term inclusive. It's a funny inclusion now that everybody is bothered. When normally we use inclusive, we mean that the poorest must get included. But here they use inclusive to mean the private sector must get included. Okay, so there is always this particular aberration in which it happens, and whenever we say this inclusive, this is this way that what is happening with language. You see how languages, words are flipped out out of a particular, and within a different discourse, they can have a completely different meaning and opposite meaning of this. And one word that we are going to see today in some depth is this phrase called strategic purchasing. Strategic purchasing has not been part of any discourse in Indian public health policy. Just not been there. The high-level expert group, I just put those two words and Googled it. At one point somewhere it says, like this new things can be thought of, like strategic purchasing. It's between two commas in some corner, but it's really not part of the discourse. And suddenly strategic purchasing is all over the place in this particular term. And we need to really understand where this term comes from and what it does, but you can actually see what it is. But before we come to that strategic purchasing, if we go past this rather thing, but the goals are set in a much more in line with the sustainable development goals rather than the millennium, they are less target prone. So that's a positive thing. But we come to the objectives. Here there's something very interesting. There are 4 objectives laid down, and the first of this is progressively achieve universal health coverage. So now we do have India going online to declare that yes, this is a goal that we also accept. We've also already done that in UN declarations. And then we say reinforcing trust in public healthcare systems. It's not bad because you are accepting that trust is at a premium and therefore reinforce. And then you are saying align the growth of private health sector with public health goals. It is also alright because we know public health goals are private sector is growing, but it is not aligned with public health goals. What other goals it has only goals of profit. And then finally specific quantitative goals and objectives. Even in specific quantitative goals and objectives, there are 3 sets of indicators. The classic trend has been to be given only health outcome indicators, like you say infant mortality rate, but this time they have actually segregated into indicators that are capturing health system strengthening, indicators that are capturing health systems performance. So it's systems performing and systems indicators as well as health outcome indicators. So that's also a step forward, even if as many commentaries has commented, some of the outcome goals are so low that without any further effort or input into it, you can actually achieve. Like it says a total fertility rate of 2.1. We are already at about 2.18, 2.2. The total national fertility rate, and without at this current rate of decline, we are going to achieve that maybe by 2021 or so. By 2025, it's not a big deal. Some of your critical indicators, like in system strengthening indicators, like your budget, it's 2.5% of the GDP. The draft goal was to say within 3 years, since the draft was a 2015 draft, you were saying 2.5% of the GDP will be attained by 2018. And now it is 2.5% of the GDP, but the target date is 2025. This government can win 2 elections before it has to. It has finished the 2024 elections also before it is called to account for it, safely put into the distance. Of course, one can calculate at the rate at which it has to spend, but you can see that the goals have been shifted backwards. So in some sense, life expectancy, TFR, some of these are going to be captured just by secular trends. You are not necessarily going to be having to put in an additional effort. That's concern one that we will flag on this. Though there are some, for example, it says public sector utilization will increase by 50%. If we say 28% of outpatient care in Maharashtra, or 20% in Maharashtra is one of the lowest in India, this outpatient care, you say it will rise to 30% by 2025. Big deal. It's not really something that is desirable even at an earlier term. So these are low set goals. The only positive thing is that the goals are across the board, and in some sense you could justify the goals by a government that is serious also. So if you were to ask the ministry, you say we are not going to set ourselves ambitious targets, we can set ourselves targets that we can achieve. So you can have the logic of pragmatism. Pragmatism is the logic with which you are also dealing with the last of these goals. The most important one, there is this huge paragraph about shall we make health a fundamental right. Remember, we said that this is an obligation under international treaty, but it puts it off again, saying that we are not yet ready to make it. If the funding goes up and if the strengthening goes up and if these things factors are conditioned, then we can consider this and puts it off into an indifferent future. But since the debate had been raised, it doesn't answer some of the key questions of the debate. It doesn't answer whether states can make it or a center can make it and under what circumstances the center can make it. And that's one of the fundamental problems of this whole policy draft. It's not been commented across widely in the comments I'm seeing, is this definition between the center and the states. See, you're making a national health policy and you could make a health as a fundamental right. One of the fundamental reasons why the center says, I can't make health a fundamental right because health is a state subject. How can I legislate on behalf of the states? Then how can you make a national health policy? You are making a national health policy because there is a clause that says that though these are state subjects, if you have to comply with international treaties to fulfill your international obligations, you are required to make policies that will need to take the state along. So it is the fact that you are part of an international architecture that is actually making you make. The same logic can be used to look at making health a right. But in doing so, you have the problem that if you are going to use that, then what happens to state autonomy, and that has to be particularly handled. And that's one of these questions that it leaves open on that. And the whole point of what rights we are talking and in the international concept is making the denial of right a justiciable event. We are not talking of saying that the hotels should not be polluting water or abattoirs right now should not be throwing their waste in the road. That is important, but that's a different area of law than what we are talking of. Here, under the international covenant, we are talking about health as a right. Access to healthcare as a fundamental right, and its denial as the justiciable event it can go. So in Thailand it is a right, and what it means is if somebody can prove that he has been denied, he has to be paid a compensation, and there is a budgetary line for compensation to be paid to people with such a denial of rights. Some article 42 or something within their particular law, but it makes it necessary. And you need to actually show that obviously what do? You don't send the doctor to jail. So the Thais thought it through this and they said actually that there has to be a compensation paid for a denial of right. So in that particular area also the governing language is the language of pragmatism and say, oh, we can't say something that is far-fetched, that we are not in a position to do, which in a sense is right. But at some point you are saying that you are not actually making a commitment to health as a right. So then, what is the remit between the center and the states? If we are saying this policy, all of these things have to be done, who is accountable? What is the differential accountability between the center and the states? Can the center say, look, we made the policy, you guys were to do it, you didn't do it? What would be the accountability of the center towards it? What is going to be the share of revenues between center and states? And these are the areas that the silences in the policy are extremely worrying about. And at some point, because this is a critical issue and the uneven development between states makes it even more critical because some states potentially can do it and some states just can't do it without a huge degree of central intervention on it. And that's one of the areas that we need to see. But coming back to a positive feature, if you look at the objective, there is a clear statement of what is the road to universal health coverage. And what it really says is that our road to universal health coverage is primary health care publicly provided, universal and comprehensive, with secondary health care largely public provided but supplemented by strategic purchasing. It says this. It says this in para 231, which is the progressively achieved primary healthcare services for all aspects of reproductive, maternal, child and adolescent health, and for the most prevalent communicable, non-communicable and occupational diseases in the population. Occupational is a welcome addition. The policy also, so this part of it is a very clear statement. And then if you go back, go further into 3.3, it says free primary care provision by the public sector supplemented by strategic purchase of secondary care, hospitalization and tertiary care services from both public and from non-government sector to fill critical gaps would be the main strategy of assuring healthcare services. So here we are talking of assured healthcare services and saying this is our strategy. It's a very affirmative and clear statement on that. The policy envisages strategic purchase of secondary and tertiary as a short-term measure. So that's an apology for it. Strategic purchasing refers to the government acting as a single payer. The order of preference for strategic purchase would be public sector hospitals, followed by not-for-profit private sector, and then commercial private sector in underserved areas based on availability of services of acceptable and defined quality criteria. In the long run, the policy envisages to have fully equipped and functional public sector hospitals in those areas to meet secondary and tertiary healthcare needs of population, especially the poorest and marginalized. Public facilities would remain the focal point in the healthcare delivery system, and services in public health facilities would be expanded from current levels. Good for you. The cautions are these. What are the corollaries of doing so? After all, we have said so in the past also. What are the corollaries? Corollaries are in money, but it's not just money. Because we are talking of purchasing versus providing. The corollary is there needs to be a massive expansion of the public health workforce. Far more doctors, far more nurses, far more support staff, far more masters in public health, far more epidemiologists, far more hospital administrators. You're going to need a substantial increase. You're not going to be able to do it if you do not have more people on the ground, and whatever the levels of efficiency, eventually numeracy matters and you need to put the numbers on the ground. Now look closely on the first introduction line and you see our first absurdity. The policy also envisages optimum use of existing. This is continuation of the first place where it appears. Optimum use of existing manpower and infrastructure. True, you need to use optimally, but you need to expand, and what would have been the priority? And advocates collaboration with the non-government sector on pro bono basis for delivery of healthcare services linked to a health card to enable every family to have access to a doctor of their choice from amongst those volunteering their services. No single line in this whole document is so absurd as this particular line. What are you talking of? You are talking of private sector doctors in remote areas coming forward to volunteer their services and family being put to it. Pro bono means without payment. Where did this line come from? It wasn't there in March 2000, December 2015 draft. What is it? It is an instinctive reaction to the fact that you are going to say, therefore, hire more nurses and doctors and hire more paramedical doctors on that. And you actually put in this particular line, and then you need to read it along with this whole reverse of this. So you have at one point, you have this particular thing, and you go right down to 13.6. So you have a para 12, which is also about strategic purchasing. But in para 13.6, strategic purchasing is suddenly means something else. And this is an insertion that if you have followed the internal discussions and even the Times reports on some of these, you would know as an insert from the Niti Aayog. The Niti Aayog sees itself as a champion of corporate interests. It is, along with the Gates Foundation, written a number of documents advocating this change. We have those documents and we know actually that this is not something random, but it is also the same document that you have from corporate max fortes. You have a number of these documents. And what does it say? It says for achieving the objective of having fully functional primary healthcare facilities. So this section, standard 13.6, strategic purchasing and stewardship, is directing areas for investment for the commercial health sector. So here you are not using not-for-profit, you are not using private sector, you are saying commercial. And then you are saying directing areas for investment. And if you go further down, you see it's not even directing areas for investment. You are saying that if there must be increased public expenditure, to route some of this public expenditure through the corporate sector so that they also are included in this group. So I have had a number of secretaries saying, you know, you've done something for the public sector, why haven't you done anything for the private sector? That's the burden of the Niti Aayog report, that you are neglecting the private sector, you are impressed only with the public sector which provides for 20% of care. You should do something for the private sector also. But what does that mean, doing something for the private care? Are you talking of strategic purchasing to improve health outcome, close critical gaps, achieve universal coverage, or to ensure that there is a stimulus, an economic stimulus, so to speak, that will pick up healthcare industry's growth? What is it being assured? Assured health services or assured profit accelerations? And 13.6 is an insertion that's very confusing. Much more so because if you see the situational analysis, there's this excellent document that comes along with it, situation analysis. Okay, this is a companion document. It's called the backdrop to the national health policy and introduced as a part of the policy. It actually states very explicitly how the government has been providing support to the private. And I assure you, this is a very limited version of what it has been doing. So here it goes in 213.2. The government has invested heavily in the last 25 years in building a positive economic climate for the healthcare industry. Amongst these measures are lower direct taxes, higher depreciation in medical equipment, income tax exemptions for 5 years for rural hospital, and customs duty exemptions for life-saving equipment. Other forms of assistance are preferential and subsidized allocation of land, subsidized professional education in government institutions, and provision for 100% foreign direct investment. The active policy enabled the private healthcare industry to attract over $2 billion of foreign direct investment in 2012-13, which as per market source was mostly as venture capital. For International Finance Corporation, that is the arm of the World Bank that deals with private sector, the Indian private healthcare industry is the second highest destination for its global investments in health. While recognizing that the growth of such industry brings in revenue and provides employment, there is a need for government to actively shape the growth of this sector so as to ensure that it is aligned to national health policy goals with regard to equity, access and financial protection. So here you say its growth, and this is the objective, a recognition of the fact that this growth is not necessarily related. To the extent it's related to medical tourism, that's a different debate. Thailand has really done it when public health system took over much of the local population. You are then saying that what you do, that the industry can survive on medical tourism. But to the extent in India, with the lack of specialists and internal brain drain occurs to carrying after them, it's not suitable. Whatever it is, it's a different debate. The fundamental problem about this particular formulation is that in some sense you are saying that you have given quite a bit, but it's not quite enough. What you are looking is a direct transfer in which you are able to do much more you are giving. And you list a number of ways. So it's not only financial. For example, one area where a lot of media attention is posed and the whole public system is whipped into, including this and everybody, is into organ donation. You are got somebody has had an accident and died, and you need to get that heart and slum and push it across to this major hospital, Medanta city, some corporate. So the surgeries are happening mostly in private hospitals, mostly to the hospitals. I mean, you need the public system to be able to generate that sort of demand that can keep the organs in flow for this particular high yielding, high return segment of the industry to fly. There may be a moral basis there that we need to examine what it is. So that finds place in para 13.6. Along with saying for primary health care, for health and wellness centers, you are going to be able to outsource these to various commercial sectors where it is possible, and then it lists that these are all the number of areas where corporate sector can be given a business opportunity. The problem with this is, as they actually point out in the earlier situation, in the situation analysis, is that some of these have been tried, they are not very well worked. And at some point, when you are talking of strategic purchasing from public sector, the unit cost of purchasing is much less. Much more important, you have the production relationships under your control, which you don't have in this area, and it becomes driven by supply and driven by profitability. You're not able to shape it to it. So this strategic purchasing term that is used in this place in two meanings. One meaning is a form of resource allocation that is able to prioritize it according to needs of secondary tertiary care and buy it from its most affordable source, but not being sacrosanct. So if there is a mission hospital working very well, if there is a not-for-profit very well, you say that, look, you can go there, but government will reimburse. So that you do not have a problem. So there is no in an area, if you show that this cannot be supplied by public sector, you immediately move on and purchase it from private sector, which itself is a huge market. It's a huge market. It's not as if it is enough to absorb all the private sector that exists, but not the private sector which defines its efficiency on revenue maximization per patient served rather than extending or looking at. So if your business model is one that looks upon maximum coverage for your dollar invested, you could actually participate in it. But if the business model that you are dealing with is revenue maximization per patient, then it may not work for you. You get this particular point that I am making in the commercial sector. There are two ways in which you can talk about it. And in some sense, you are not really going to have much of a buy-in. And that is the reality of it. The reality of it is you call the corporate sector into a meeting and say, are you willing to perform this particular care? They are not willing to. They are even willing to pay back. So Fortis, for example, has an agreement because they have got free land to provide some 10%, 20% free care. Now, even if government is willing to chip in and pay it, they don't want to, because at some point their business model requires maximization. It requires a very rich patient, and some poor woman lying over there, not within the same status connotation, this actually undermines their market strategy. And therefore they are saying, look, we are now willing to pay for that land at some negotiated rate and get out of that agreement rather than rate. Though actually at any given point of time that number of beds may be vacant also over there. And that was a line that was there in the original draft that got dropped. It's a huge issue. The problem with some of the lines related to human resources are most well. There's a specific, instead of say the 11th 5-year plan lamenting that doctors don't go to rural areas, there is a proactive commitment to how this can be addressed. There's a proactive commitment, there's a commitment, there's a recognition of the specialist gap and some proactive measures being considered. I think they are incomplete, but they are steps in the right direction. This whole notion of mid-care providers has met with a lot of professional resistance, but there is certainly a huge scope in down that particular road, and those are pragmatic solutions. In the area of access to technologies, there's a lot that has been said over here that's pretty good. So there is talk of regulation of medical devices, there is talk of regulation in the food area, there is talk of regulation in what is it? There's a whole page of issues of that on. Food safety, drug regulations, medical devices regulation, clinical trial regulation, and pricing regulation, vaccine safety, good formulations. The problem is, of course, clinical establishments regulation, which is so critical to your whole understanding of is particularly devastating. All you are able to say is that only 4 states have really subscribed to it, and we will use advocacy to persuade other states to come. But the Clinical Establishment Act is 2010 and 2017, and all that we can say is advocacy. In some sense, you are saying giving up on the possibility of regulation. The same thing is the problem with the professional councils. If you do not have the professional councils into a non-corrupt governance, then what this whole move for the National Health Council for Human Resources, that larger body, Human Resource Council. If you are actually not a viable alternative, though I saw in the papers there's some talk about it, obviously the criticisms will be sharp, then none of these plans are really going to work. So other than in regulation, where it comes to professional councils or clinical establishments, in the area of technology, there's some, even in drug innovation and discovery, even in research, there are some good ideas over there, some essential policy formulations that are important that can be actually followed. So in some sense, clearly, the areas of contestation are the areas where you are really seeking to push private sector participation. But in drug innovation, even public procurement and the role of public innovation is structured and much stronger on that, and I think there is a good issue. So if in private sector, your failure is basically that you are promoting strategic purchasing without either a clarity of for what outcome you are purchasing is purchasing for better outcomes or for stimulating industry, and you are not got regulation in place. The problem with your public systems, the strengthening of public systems on a public architecture is that your government section has become weak. So what's your big problem in the public sector other than human resources? It's accountability. And within the factor of many areas of accountability is corruption. So the draft policy in one interesting paragraph called fiduciary risk reduction. So you don't say corruption in polite language. You say fiduciary risk reduction. FIDUCIA, fiduciary risk reduction. In this paragraph, it sets out that there are 4 basic reforms that will be able, 4 or 5 evident basic reforms. This is the draft policy, which are needed to curb corruption. 1, transfers and postings on a positive manner. There's a best practice in Karnataka. At any time you can see which are the vacancies and who are the people wanting a transfer, and according to seniority in what is called the counseling, so no counseling happens, you are able to actually shift these people. Your second major area is in drugs procurement, and we now know that Tamil Nadu has never had a very good system, Rajasthan has followed, Kerala has a reasonable system. We know what works to ensure good drug supply without corruption. They are very simple to the government to have said, if you don't do this, then central funding, you can't cut funding to Bihar. But you can say, you can't give it to you in money, we will give it to you. Right? You can say that. You can even ask Rajasthan to purchase and give it to Bihar. Because whether they send it to Jaisalmer or they send it to Araria, doesn't make too much of a difference. It's just some question you can actually organize that purchasing along that ground. It's not an inherent problem in peace. But eventually, there has been a reluctance to say so. The third major area, key appointments is there, and this whole contracting in public-private partnerships and grants to NGOs, in infrastructure, 1 or 2 areas. It says, if the systems that are to be put in place for these are benchmarked with the best practices in India, then at some point you are made an accountable system. We are all pareshan about that A&M who takes 400 rupee bakshis for the delivery. That's not the major source of corruption. That's not the thing that erodes the system. What erodes the system is something called selling the budget. The way it works is you have a budget, the minister goes and the director goes and he has to give it to the districts. So he says, okay, your budget is 3 crores. So the district CMO will say, okay, here's your 30 lakhs. And then he gets the check for 30 crores. Now how does he do it? He has already got into a deal with the pharma industry and gets a certain order with them, for which they have advanced the money and they are going to get that particular order. So the major, similarly transfers and postings. If you have paid through your nose to get posted in one particular place, the person to whom you have paid is in no position to exercise authority for you on which if you don't come to work. Right? And it is very typical that some of the honest young doctors and nurses who are working, who refuse to pay, may get harassed more than the persons who are not working because they are not paying. And therefore they tend to be always in a certain degree of tension and fault finding within this whole system work. So actually this whole issue of accountability is not an issue of the peripheral provider behaving badly, though he does have bad lessons and bad role models to follow. But it is a failure of leadership to actually build robust, transparent processes in the leadership level. And at some point, your public health system strengthening needs to identify and ensure that very well known best practices to prevent this. You see these ombudsman approaches, these approaches of catch and punish, are not as effective as the avenues that block rent seeking. This in World Bank language is called rent seeking. So a chief medical officer or a minister makes money by virtue of his office. You pay to him by virtue to occupy this post, you pay to him. So this issue of rent seeking actually has a systemic requirement of its own. What am I saying? I'm saying corruption has a systemic requirement of its own. And therefore at some point the issue of governance handling this has to deal with what is called this issue of fiduciary mismanagement. That paragraph goes right out. Just gets dropped. And what you have is a paragraph that says we will do community monitoring. Okay. Now, I'm not against community monitoring, that's very good. But community monitoring can see only as far as the nurse and the local doctor. And there is a mile that you can gain out of that, but it somewhat misdirects the main source of misgovernance and gives you a long reason and pits the people against who should be their main benefactors, which is the public health workforce. In some sense, between the whole thing. And it's extremely important that I'm not saying that it will always do so or it is doing so, but at some point they don't even finally finance it. So finally, whether you can do community monitoring on a better way, after so much talk, they don't really finance it. So these are systems of governance that actually central financing can impose. You can very well say that I will not give money for a district where your district health officer is not appointed by due process. Central need not encroach and say what process. They can choose by lots or they can choose by alphabetical order. But it is better by choosing by those who pay rent. Right? So in some sense you find that there are these silences in the policy that needs to be concomitants of what you need to strengthen it. They were there in the draft policy. They actually get selectively removed, and what gets inserted is at the private industry interest. So if you have a political class that would seek the health system for rent seeking and a private corporate class who would like money made through it, that potential exists in this policy. But the policy also has the great potential, has some great ideas in it. It has health and wellness centers. It has one big idea which is also a reverse. Selective healthcare came with structural adjustment policy. Similarly, the other thing that came with structural adjustment policy was the issue of user fees, cost recovery, which meant what? If the hospital had to recover costs, then the question of free drugs does not arise. You are charging even for consultation and fees. And the poorest states like UP and Maharashtra also has that policy, would collect money and not even spend it in the hospital. They would remit it to the treasury. Because like a private public sector unit, like a steel plant making money, you are supposed to use the hospital to earn money. Complete perversion. But this was the policy that was actually introduced by the World Bank through conditionalities in the 1990s. Now, the great thing is this says clearly we are moving away from user fees and cost recovery to free drugs and diagnostics. No. That's well. But its correlate is that you need a better public procurement policy, but also much more that you really need to do. You need to carry it out, and that requires more budgetary allocations. And to the large hospitals. Is that happening? We don't know. In January, there is a circular that has been issued by the Central Ministry. It says that the Seventh Pay Commission recommendations to implement, you will need higher revenues, and 30% of those revenues have to be generated by the hospitals themselves. They are not saying only hospitals, they are talking hospitals. They think 30%. What would it mean for a place like Chipma or KM hospital where most of it is free? It would mean imposing user fees. How do you reconcile that with saying that I am going to extend free care? And free care does not mean 5 days of free care when you come there. It means 30 days of tablet provisioning so that you are able to move across them. So you can see that at some point you have a number of policies this way. But look at it this way. To draft the policy, there was a struggle. And everybody weighed in and we got a policy draft. To pass that policy, there has been a struggle. And let's not be surprised to implement that policy, there will continue to be the struggle. The policy is only one milestone in a long process. So you may choose to jump in and say, look, we have set health and wellness centers under the public health system with more staff, or you may choose to jump in and say, you can outsource this. But all policy, the gap between policy and implementation is a process of amplification and attenuation. What lines in the policy you play up and what lines in the policy you play up. That's not only, it's also a political environment that does it. So if you see the NRHM framework draft, it has all these vacillations. But what got amplified were much more positive areas. Because that was a consensus. There was a UPA government with referendum, there was a need for strengthening public system. That had been the electoral manifesto. So what got amplified was much better, what got attenuated was different. Now again that process is there. Therefore, political environment also matters. What is being said, administrative environment matters, but civil society action and academic action also matters. Also, evidence matters. Evidence does not necessarily make policy, but evidence is a huge stakeholder in negotiation. A particular position which can marshal evidence in its favor can tilt the balance of negotiation. So if somebody is saying that free care in public hospital, look, it shows reductions in poverty level, it shows reductions in impoverishment, it shows a greater access, and therefore this is the cheapest way to look at this reduction of cost, then the people who are arguing for it actually get strengthened. So it's a dynamic process that's ongoing, and in some sense a part which all of us there is a part to play. It's not something the policy is made there. You are empowered to influence it by the nature of evidence you come to bear on, by the nature of mobilization you bring, by the amount of public understanding that you create around policy. I think therefore the People's Health Movement little knows in its own self how much of an impact it has made in shaping policy in India in the health sector, it has made quite a huge amount. And think today that this policy could have been much more. I think there are so many positive features in this policy. Some of the problems I said are some of the gaps through which it can get subverted. But eventually there are things in this that are opportunities, and there are fault lines running. What finally becomes of it is how it gets. Let's stop here and take questions on this. If you have a policy, you can yes. Start off with a few questions that you will have. You can have alternative views also. Don't be constrained to look at my reading of the policy.
This was training the management. Can policy the management as an answer there is management. So we take on the management.
I think that is a very well crafted and it's a reasonably well crafted policy. I'm not a mental health policy expertise, but you can also see that today they have passed a national mental health policy. There is some seriousness on mental health. Okay. Again, implementation of mental health cannot happen without strengthening the system. But the point is, you see, what happens is around each of these a policy community forms. So when there is a policy on mental health being made, there are some people being consulted. And somewhere we have some right-minded, right-thinking policy over there. So yes, that is one of the, both that and on NCD, but on mental health, it says, increase creation of specialists through public financing and develop special rules to give preference to those willing to work in complex systems. They could have said it for all specialists. But at some point what it means is there are no psychiatrists in the public health system. And at the apex you need psychiatrists. All the people who pass psychiatry go to USA. USA has a huge shortage of psychiatrists. And I think they are going to need even more with the present president. Okay. And at some point, there's nobody left behind. And there are people who want to practice in India. But this whole system of selection will actually explode. That is one very clear thing without going into it. Create network of community members to provide psychosocial support to strengthen mental health services at primary level. Community members are far, but at some point community health workers, etc. leverage digital technology in a context where access to qualified psychiatrists is difficult. What we are really talking is of telemedicine contacts which work between primary care providers or any person with an MD in medicine or even an MBBS can manage a lot of psychiatric care. But given the nature and trends in education is unable to. But backed up with a telemedicine support, it could be a mobile call, you can actually do much better. But then there must be fixed times in which the consultant psychiatrists are available and you could be anywhere in the world they are sitting in to do better. So there has been some thinking into this. It's not enough, but it says something very interesting. It says the policy will take into consideration the provisions of the National Health and Mental Health Policy 2014 with simultaneous action on the following fronts. So in some sense what it is doing is saying that all that is there in this policy is there in this, but we are flagging these concerns. That's, I think, one of the consequences.
So you spoke about goals, like the total fertility rate goal is close to sustainable and pushing back to 2025, but there are certain indicators like, say, Kala Azar and tuberculosis which are being sent for 2018 and 25 respectively. Do you think those goals are going to be feasible to attain?
Good question. In this sector on communicable diseases, they have done an interesting organization. So the first line is on HIV. The second line is what is called neglected tropical diseases. So they have identified 3 neglected tropical diseases. I have a running battle with them to include snakebite in this list. It will happen sooner rather than later. But right now it has they are all elimination, and you can't eliminate snakebite, so perhaps nobody thought about it. The moment they say eliminate snakebite, then anyway, elimination stages of leprosy by 2018, Kala Azar by 2017, and lymphatic filariasis in endemic pockets by 2019. But here's the problem in this. In absolute If you look at elimination as zero disease, that can't happen. Many people who have already got infected will develop the disease down the line. Even if you have a full survey and have identified every leprosy case and treated it, next year you will have more cases of leprosy. But then, you ask the policy maker, he will say, my definition of elimination is less than 2 per 10,000. But then the problem is you have already achieved it in 2005, which of course is not 2 per 10,000. Our estimate is that in a state like Maharashtra it is 3 to 4 times that, and in a state in UP it's 20 times that. But even said that, it's still very low. It's still the incidence is very low. So there you note this particular line which says that in endemic pockets by 2007. Which means that in leprosy, there are a lot of blocks, about 60, 70 blocks, where the rate is more than 2 per 10,000. You are saying you set a target for that. That's a good idea. It's a good idea. But at the technical level, we have a bit of argument to do, because if it's a small area, then you will get it. And then in the large district, you may have many more leprosy cases, but it may not be 2 per 10,000. And there's an absolute number required as much as a rate required for estimating it. But essentially, it seems to me that they have got this nuance right. Well, again, like in all policy, somebody has to translate this and provide a list of blocks which are endemic at the baseline and show those blocks have reached control by that particular year. Will they reach it? Is still a question. My guess is they won't. Not by 2008. But I don't think I would blame them. I think I would blame the policy maker for not understanding epidemiology.
So then elimination is a wrong terminology.
Basically, they needed to, but then it becomes complex in a document to set in these blocks we will estimate this way, these blocks we will estimate that. In the sweep of it, perhaps this is one of the more excusable problems. But you can see that a lot of thought has gone into the formulation of that particular language.
How does this national health policy influence the private health insurance market?
How does it influence private health market? It's interesting. One of the interesting things to do is to watch how the shareholder market behaves. Like the year when there was a major policy cut, the finances were actually reduced. The share prices jumped up. So I went and asked my friends, whom I have a lot of friends in the government area. So I asked them, look, what are you celebrating? There's nothing for public system, but there's nothing for you also. They said that we have moved a lot of people from employee service insurance and ESI and this are now eligible for private insurance and will get tax breaks for private insurance. All of those were seen and seen. So market responds to signals. Market responds to policy. Over here, the market they have been very quiescent about the policy now. There have been no major policy statements that have come in. What does it mean for private insurance market? Private insurance is not about strategic purchasing. It's about market-based purchasing. The term strategic is generally used in 2 or 3 contexts. And in this context, it doesn't enter. There is another context of usage where you say the individual can't make a purchase because he is vulnerable. When he goes there, he is sick, he can't negotiate with the doctor. So he has an intermediary making a purchase for him. That person will purchase on the basis of competition and choice. And therefore, the strategic purchaser's main aim is to stimulate competition and purchase at the lowest rates by competitive bidding. That is one usage of strategic purchase. That would have been a good film for private insurance. That's not mentioned here. That's not over here like it. So I don't see them. So in the last budget, the National Health Protection Scheme was announced. It was to be launched by April 1st. The budget was to be increased, and it was to be the architecture of the major thing. The sum assured in RSPY was to go up from 30,000 to